you got to be ready. How would you calculate, right? If I tell you a person is breathing 80% oxygen, calculate it that way. If I tell you a person is breathing 100% oxygen, just be ready. What will be the partial pressure at the alveolar level? How we did that question for the clicker, right? So just following that, you can very well plug in those numbers. Does everyone remember this equation that we did Friday? Is it clear enough? Does anyone has questions? Please ask me now. Are we good with this? Okay, Abdul, you have question? Please go ahead.
For the exam purposes, is it RER always going to be 0.8 or it can be different?
Yeah, we just gonna give you standard. Just go by 0.8.
Okay.
I can explain. So tomorrow morning when I take the class, I will go over this again one more time, and we can talk about if the diet is different, like if you have just protein diet or just carb diet or just lipids diet, this can change a little bit, but we're not going to give you that in exam. So exam, you assume it's 0.8 standard. Just keep it standard. Okay?
Thank you.
Yeah, I'll talk more about it tomorrow morning when I take the class, and I'll explain you where we get this number 0.8. I just don't want to waste time now because I know everyone wants to go back and study. Be ready with your alveolar ventilation equation, right? So alveolar ventilation basically is taking extra carbon dioxide that will be sitting if you are making more during exercising or other conditions. You want to bring your ventilation up in order to get rid of that because they have the inverse relationship. So keep that in mind. Is everyone ready with FEV1, FVC concepts? Are you all good? Anyone needs help with this?
Yeah, could you actually go through the graphs?
Yes, absolutely, Jusha.
Thank you.
So here, if you look at these graphs, first of all, you want to appreciate the number here. Does everyone understand what is the difference between FVC and FEV1? Are you clear about that? So FVC is your forced vital capacity. This is the maximal expiration that one can do after doing maximal inspiration. So you're trying to forcefully expire, and how much you can expire is usually measured by the pulmonologist on spirometry. So if you see this is a healthy person and they have near about 5 liters. So here is 2 to 7, 5 liters of FVC this person has, right? And when you are trying to expire this air out, you can get basically most of the volume out. That's your 4 liters, as you can see here, 3 to 7, 4 liters in very first second. So you get rid of all this air in basically 3 seconds. You see here on this graph, 3 seconds you get FVC out. But very first second, you already got 80% out, 4 divided by 5, right? So normal ratio is 80%. Yes, Jessica. Jessica, you have question? You are on mute.
Yeah, I know. I just unmuted. Sorry. So the FBC at that bottom, like all the way at the bottom. So we're saying that 2 liters were left after the full expiration.
No, only 1 liter is left, right? You got rid of 4 liters in the very first second, right? You have total FVC is 5 liters, right? From 2 to 7. We always have the expiratory graphs downwards. That's how they will show on the spirometry.
Okay.
You see my point?
Yeah.
So here is your FEV1, which is 4 liters. In very first second, a normal person will get most of the breath out, right? So
Yeah.
your ratio would be between 70 to 80% is considered normal, right? Now, if you look at the obstructive disease, I explained it Friday as well. So just know that there is a difference between obstructive and restrictive disease. The examples for those could be restrictive is fibrosis. Why we call it restrictive? Because patient is having problem inflating the lungs or keeping the air in the lungs, because lungs are very scarred, they are thick tissue, they're fibrotic. So moment they breathe in, they snap back and get the air out. So inspiration is a big issue for these patients. Now, if you look at this FVC number and compare this, this is only 3 liters as opposed to a normal person who has 5 liters here, right? And same thing is with the obstructive disease. So, mainly COPD is covering, like it's an umbrella basically. So it covers so many other issues underneath, like emphysema could be one, and if it's a chronic asthma, that will also turn into COPD, right? That will be a chronic stuff. So where you have issues at the airways, so patient is having obstruction in the airways, right? They'll have hard time getting the air out of the lungs. So now if you compare here, FVC is reduced definitely to 3 liters, but they will have problem getting their first volume in the very first second. The air that they are getting out is only 2 liters, right? You see here. And here it's 3 liters, where almost 2.8 liters you can see, where your FVC is 3 liters as such. So if you divide 2.8 by 3, you can see that they are more than 90% that they are getting out in the very first second, because their lungs are just snapping back. But here, we can take example here for emphysema, where lungs have lost the compliance and they are actually getting more air in, and they are highly inflated, and it's very difficult to deflate these lungs to get the air out from the airways, right? So only 2 liters is getting out in the very first second. So if you get the ratio is decreased. FEV1, FVC ratio is decreased here. Whereas here, the ratio will be increased. So now you got to keep an eye open what kind of stem you are getting in the exam, whether the ratio is increased or decreased, what kind of pathology it could be as far as the lungs are concerned. Okay, Joy has a question, Joy?
Yeah, so I might just be realizing this. But so since FVC is relatively lower to the normal in either disease type,
Yeah.
is that because of like the tidal volume? Or because FVC is scaled off of tidal volume and not total lung capacity? And like, is total lung capacity then in theory still the same, or is it reduced because of the other histological changes?
Yeah, so both pathologies, they have different kind of numbers. The total lung capacity for the emphysema is actually increasing, because patient will be having the residual volume increasing because they are having hard time getting the air out of the lungs, right? The foul air will be sitting there. They'll be having some retention of carbon dioxide getting in there, right? So because they don't have their lungs that healthy anymore, their alveoli, they're not very healthy. I'll go one by one. I just don't want to give you all because we haven't finished the question. So I'll bring the next slide and I'll explain you how all these numbers are changing. Let me go to the next slide and I'll explain it more. But FVC is reduced in, FVC is reduced in restrictive, and total lung capacity is also decreased in restrictive disease because lungs will have hard time keeping the air in. So their TLC, their total lung capacity is going to get decreased as well. Okay,
Okay.
there are a few things. Let me read off the chat and then I'll go there. So Deborah is asking in COPD, lower value of FE1, FBC, decreased exhalation, therefore lower ratio. No, the RV will be higher, Deborah, because they are having hard time getting that air out. Inspiration is not an issue for them. It's basically, I mean, it could be an issue, but mostly problematic for them is they are losing in COPD, they'll be losing the lung compliance, right? Because they have lost elastin fibers because of years of smoking or something like that. You know, if they have done that damage, the elastin fibers of alveoli, if they are gone, the lungs are not snapping back that nicely, or they are not recoiling back that nicely, right? So they'll be retaining more air in. So Diego is saying, is it correct to say that the ratio of the restrictive disease is somewhere above? Yes, yes. You're absolutely right. It falls between, sometimes the ratio may look just similar to normal, actually. Diego, it may look just normal, but then you can always take a look at the FVC value. And if it's much lower than the normal person, and then you know, okay? And as Erin was asking earlier, I'm going to go over the loops so you know what to look for if you're looking in exam, how it will look like, okay? One more question was there. I'm just going back. Michael is saying, yeah. Andrew is saying a restrictive rising ratio are, okay, yes, very nice. Okay, what is Deborah saying in COPD? Yeah, okay. Islamia is actually responding to them. What are they saying? Won't the RV be lower regardless of restrictive? No, no. Let me just bring that chart up and then I will show you what I'm trying to say. Mm. 1 second. Somehow I think I have the wrong file. Does any one of you have the file, the right file that we went over Friday? Do you have it open somewhere? Or I can pull it. All right, I found it. Just give me 1 second. You can see my file, right?
Yes.
Okay, thank you. So this is what I was trying to tell you guys. So if you look at the obstruction here, right? And I was telling you guys that these patients are having hard time getting the air out. Their residual volume, how much it has increased, you can appreciate that. See how big it is because they are trapping that air in the lungs and it's so difficult to get that air out. Now compare that RV to a normal RV, it's much larger, right? So their total lung capacity, which is comprising of their ERV, RV, their tidal volume and IRV, right? whole thing, their TLC is much more increased than a normal person, right? Now, if you look at the restrictive disease, since they are having hard time keeping the air inside the lungs, their ERV and RV are much reduced. Is it making sense? Are you guys getting my point? Parambi, Daniel is asking something. Daniel, what are you saying? I will be posting the recording soon, yes. Okay, I can explain it one more time. Can anyone speak like what exactly you're not getting? Because I don't know, there are a couple of things in the chat. Yes, Abraham, please.
So my only question is for obstructive lung conditions, will they have a smaller vital capacity then, since their residual volume has increased?
Yeah, so if
Okay.
you compare, if you compare here,
Mhm.
you can very well see, the vital capacity will be changing depending upon how bad the COPD condition is, right? So
Okay.
I told you a few times, and we had question in the clickers that day. If you recall, I had given you this question, right? Where I told you, okay, FV1 FVC ratio is this much, right? But when you gave them albuterol, which is your beta 2 relaxant, this ratio is improving to 76%, right?
Yes, ma'am.
Always remember that asthma doesn't have anything wrong at the alveolar level, right? But COPD is a problematic condition where the damage, it's chronic inflammatory disease, right? So it has been, or you can say chronic obstructive, right? Pulmonary disease that has been there over the years. So there are more problems that have happened just besides the obstruction at the airway level. There are lungs that have been now pathological. The alveoli, they're not so good anymore. They have lost the surface area. I'm bringing that question up just in a few minutes. Erin, you have question?
Yes, just to clarify, is the normal value for the ratio we would expect around 80%, and then the normal value for FVC would essentially just be 100%?
Yeah, I mean, if you take normal FBC, I mean, yeah, basically you look for the ratio, right? And this
Okay,
will be very much clear from the stem that we will give you.
okay.
Okay.
And the other options, would they just not be correctable by a beta 2 agonist like albuterol?
So if it's exacerbated, I don't know how to say it, but if it's a long-term COPD, then it may not be able to have much effect with the albuterol itself. Rather, you want to put your patient on steroids to bring the inflammation down, and maybe you have to add, atropine, the Atrovent, muscarinic antagonists to bring the secretions down as well. There are a couple of things that are going on in the airways that time if it's a long-term COPD, right? So there's mucus built up in the airways. There could be like heavy inflammation sitting there, which you want to bring down. And all those things, you would need steroids for that, and you would need probably the muscarinic antagonists also. You see my point?
Thank you.
So you cannot, I mean, you can give some relief to the patient. It's not, you cannot bring it close to a normal, 80 or 76% as this stem is telling you. You will see it. If you are seeing a COPD stem, I'm actually going there now. So let's do one question and then you can appreciate it more. So this slide is much more explaining here actually. You can go back and it's already posted so you can see. So I gave you the ratios. I gave you how it's decreasing, right? I also gave you COPD if it's mild, then it's slightly lower than 70%. Moderate is, more than 50, but severe is going to be even lesser than 50%. So you will see all that in the STEM and you will be able to answer. We're not going to play with the numbers there, okay? So you will see it very clearly. So Daniel was asking, this will be posted. Yes, this will be posted. And so Ismail, can you tell me like what thing you want me to repeat or re-explain? Islamia? Am I saying the name correct? Okay. All right. All right, so let's move forward and let's do one question. Did everyone go through this glossary already? Please go over these things because these are going to be very relevant, like what is compliance, transmural pressure, minute ventilation, intrapleural pressure, what are the numbers? Okay, JP's asking, did you say VC? JP, I just mentioned vital capacity is not going to increase because the RV is increased. It's actually, it will decrease depending upon how much air is already sitting in the lungs and how comfortable the patient is inspiring the air and then, expiring that air out. Okay. Yeah, we will talk about, Michelle, the hysteresis we'll talk tomorrow and transmural pressure too. Maybe if I have time today, I'll probably go over it. Did you understand my point, JP? Regarding the vital capacity? Okay. All right. Let's move forward. So this was the question that I was talking about. Now, tell me who can be a volunteer after reading the STEM. And what do you get from the STEM, really? What does it tell you? You got to look at the age, the smoking history, productive cough, obstructive disease. Yes, Michelle, don't worry. Very nice, Islamia. Yes, you are absolutely right. Not gonna say it. So anyone who is ready with the answer, please let me know what do you think you will put this patient on. And what's the mechanism? Any volunteer? Yes, Parambir. Do you want to explain it? Yes, Aaron, please go ahead.
Okay.
I was going to say that for COPD, we have trouble exhaling. So we would have hyperinflated lungs because we can inhale really easily, but it's harder to exhale. So it looks like, as you said, we're using steroids, a beta-2 agonist, and then ipratropium is a muscarinic antagonist. So that will block acetylcholine and essentially
Yeah, very nice.
decrease smooth muscle contraction. I'm not sure.
So, yeah, I mean, basically, so if you have acetylcholine release, your action is you are contracting the smooth muscle cells, right? Or the airways are, so the contraction of so one hand you are giving beta-2 relaxant, right? You also want to add acetyl or cholinergic antagonist there or muscarinic antagonist in order to reduce any contraction that can happen. You open up the airways more, and killing the other bird is you bring down the secretions, right? That's a bigger thing. Remember Dr. Fisher's video from the beginning? All the secretions, right? So you want to bring the secretions down because the stem told you that there is productive cough as well, right? Yes, Abdul?
If it was the same question, but I asked, what is the mechanism of beta-2 agonist? Would the answer be C? Or,
Yes. Yeah.
thank you.
That's what, yeah, that is also you should be ready with. So this question was actually pretty good in my opinion. I added this because it's helping you with ANS, and it's also helping you with ANS farm, right? It's talking about all the mechanisms, right? If you are bringing the cytokines down, you are basically talking about the steroids, right? So anyways, ipratropium doesn't work through mast cells, so that is out, but other three are giving you the mechanisms there, right? Is everyone understood? Yeah, okay, perfect. All right, so this is a good question, and there are some notes also, speaker notes at length that you should definitely look at when preparing for the exam. Okay, all right, next question. Any volunteer?
I can go, Dr. Carr, if that's okay.
Go ahead, please.
So compliance and elasticity are inversely related. And so if you have a higher compliance, that means the elastance is lower. And so in emphysema, you're losing the elastic fibers. And so therefore the compliance would be higher.
Yeah, very nice, Alicia. Very nice. Yeah. So basically, lung compliance is how compliant they are when you are trying to inflate them. And then if someone has lost those elastin fibers in there, that will also lead to more compliance in the lungs. And that is what is happened in this patient. If it will be greater only in case of emphysema. Can anyone tell me one reason is, okay, they lost elastin fibers. What is the other reason? And how did you rule out the other options here?
May I?
Yeah, please, Parmdeep, go ahead.
So, E was, yeah, I was able to knock out E as an option right off the bat because fibrosis is a restrictive disease. So that was out of the way. And then pulmonary congestion did not really make sense. And then a decrease in surfactant levels is only present in infants or premature infants, and bronchoconstriction didn't really make sense either. So emphysema made the most sense because, as Alicia said, the compliance is inversely correlated with elastins.
Very nice. Okay, I'm just gonna add few things per minute if you don't mind for others as well. So yes, you are right. The surfactant levels, they are low in infants, but there are several other reasons. Dhruv is writing something. Yeah. So surfactant can go down for several different reasons. There could be a mutation also that can bring the surfactant down, or sometimes, atelectasis at older adults, like very aged adults, that can happen. So the alveoli, they are not opening up as good. So that can happen. And that can bring down the compliance, right? So all other options, pretty much, they are bringing the compliance down. That's why we are knocking them out, right? Interstitial fibrosis is gonna lower compliance. Congestion can also bring the compliance low because if there is some bacterial infection, that can work on the compliance and bring it low. So emphysema is the only good option here, but Very well done. I liked your answer. Thank you. I think you're doing very well. All right, so yes, Dhruv and Islami, you're right. Absolutely. Just go compliance as distensibility. I put the easy word out there, so just keep that in mind. But I still didn't get my answer. What is the other reason that compliance would be more in case of emphysema? Anyone?
Is it something to do with like the need for more oxygen? Something with like all the O2 levels and stuff?
No, I'm sorry. Abraham, yes, please.
I don't know if this was already said, but it might have. But for emphysema, because you have the alveolar septa and capillaries like destroyed and the elastic recoil is reduced, you don't have that negative resistance, so it not automatically, but it naturally expands. So that's why it is more compliant to expand than to go back down. It's like almost
Yeah, but that's the same reason, right? Elastin fibers are gone, so the recoiling is gone. I'm
so
asking
you're
any
eliminating
other
the
reason.
surface tension force. That's what I'm trying to describe. Is the surface tension force is gone.
Yeah, the surface tension is gone. Very nice, because surfactant is not good enough there. Yes, Amanda, please.
I was going to talk about like the alveoli kind of coming together, and that would decrease the surface area. So that would have like the lungs to sensibility increase more easily. So there would be less elastic resistance, I believe.
Yes, absolutely. Abraham, I'm just adding to what you said. Amanda just mentioned clearly. So if you can see here, so what is happening in, as I said, this is exacerbated COPD, right? So over the years, what smoke has done, smoke has what? It has tar, it has formalin, nicotine, all other carcinogenic compounds, right, which are going and destroying not only the inside capillary beds, but the walls are so inflamed and destroyed, right? So they are very thin now, and alveoli, they'll be merging together and opening up, so as you can see here, right? They are very big, damaged and enlarged. So patient is losing surface area, the capillary network there, elastin fibers, and also merging together. So this is all thin walls and all that stuff is basically leading to more compliance because they can distend more, right? I put pulmonary vascular resistance here. You can ignore it at this point, but we will be talking about it in week 3. I just don't want to confuse you guys too much at this point because it's another like whole discussion, but we will get there point by point. Okay. Is everyone clear? I can move forward. Yes. All right. Now, anyone who can explain me what is FRC? FRC. What does it denote? Yes, functional residual capacity. Very nice, Amir. What is it comprising of? Oh, Usman has already given us the answer. This is basically your expiratory reserve volume and your residual volume. They both stay in your lungs, right? So inside how good is the compliance, accordingly, your FRC will be changing. That is the whole point. So if there is any pathology going on in lungs, the FRC will be changing. Now, can anyone explain me what will happen in emphysema and what will happen in case of restrictive disease to FRC? If you can think of this previous slide that we went over, you can remember this slide. Can you tell me what will happen to FRC and what will happen, what will happen to FRC in case of emphysema? Okay, somebody answering already. Will have greater FRC, very nice. And restrictive disease will have lower FRC because their compliance is not as good, right? Is everyone clear about this part? You can appreciate from the graph here. This graph, as you can see, this is the normal FRC range that you are looking here, right? In case of emphysema, since the compliance is so high, the lungs can expand more and they are having hard time getting that air out. They are retaining more ERV and the residual volume. So this is all staying inside the lungs, which is basically leading to more FRC number in case of emphysema. But fibrosis, because their compliance is low, the lungs can't expand as much, they have lower FRC number. You can see how much it has declined from the normal level. Is everyone clear about this? So be ready with all those questions. I actually made a nice chart for you guys. So tomorrow morning, I'm going to give you a few exercises to work on. And you'll have holidays as well to work on those. They'll be very helpful for you guys for the exam. And now we go to the curves, as I was mentioning earlier. Amir is saying something. Amir? FVC or FRC? FRC, okay. So, Amir, FRC is functional residual capacity. So if we go back to this figure back again, if you can recall, we talked about it. I thought I had the graph as well here somewhere. Yeah. So what is your FRC? FRC is comprising of your expiratory reserve volume and your RV, right? This is your functional residual capacity, right? So now what is happening in this patient? If they have emphysema, they are retaining more residual volume. You can see how much, almost double the amount this patient is retaining, right? And since ERV and RV are making FRC for anyone, their FRC number is more now. And if you go to the restrictive disease, you have lower RV and ERV, your FRC is reduced here. Make sense? Amir? Okay. All right. Let's move forward. All right. So yes, this is important for board exams. So I always bring it in. As you can see, this is what you will be getting on the spirometric instrument when pulmonologist is measuring their PFTs, the pulmonary function test. So the patient is told to do the expiration and inspiration. As you can see, the curve is nice. This is all normal. So when they are trying to expire out, there is flow rate, and this is the curve which is explaining the rest of the breath getting out. This is in first second, right? Which is the peak here. Okay, Michelle is saying something. Is it safe to say all the values for? I think they are kind of low. You can compare those numbers. They're pretty low, but the curves you will see, Michelle, now on the next page. That's what I was trying to bring you at. So this is a normal numbers that you would look for, right? The flow wise and how nice the curve is here when the patient is trying to expire out, right? Now, if we go here, you can take a peek. This is a normal person. This is how the curve would look like. But in case of mild obstruction, you will see this curving because they are having hard time to breathe this air out. The expiration curve. And overall, if you see their vital capacity is low, right? As this dotted line is normal, right? The dotted line is normal, but with the mild obstruction, even this coving is there and they'll have hard time expiring the air out. So this is how obstruction would look like. If you see coving on your exam question, you very well know that this is a case of COPD that you're looking at, or asthma or something, right? As far as the stem is telling you. But if you look at the restrictive disease, see the loops look very similar to normal. It's just that they are very smaller. Does that make sense, Erin?
Yeah, so just to clarify, we know for an obstructive disease, we'd have more issues exhaling, so that's why you see the coving.
Yeah.
But for restrictive, isn't it like all you inhale and then all of it leaves really quickly? So what is that last one really showing, like the smaller curve?
It's just that the numbers won't be as good as normal, right?
Okay.
The numbers will be much smaller, but the curves will look very similar to the normal. There's no coving or anything.
Okay.
That's all. But we won't ask you more than this in first year. Just keep that in mind. I just wanted to give you guys a peek into how these things should look like when you go to the second year. So I didn't want to give like the whole information yet. You will learn it all in second year, but at least you know a little bit how these curves on spirometry should look like. If it's obstruction, you will see this coving. If it's restrictive disease, you'll see similar to normal, but very small numbers there. Okay? That's all you need to know for this exam. Okay? Clear? Diego, I didn't cover this in DO class either because we didn't get there, right? So this is already in the file that I sent you guys, and this is all you need to know. That's why I wanted all of you to attend this review session, since we didn't have supplemental for yesterday's session, right? But if you have any questions, you can come back to me again. Yes, yes, Islamia, this will be recorded. This is recorded and this will be sent over. Yeah, no worries. Okay. No, you don't have to know the top graphs. Yes, only just these lower curves. I wanted you to know like how these loops look like. Yeah, the PowerPoints, I already sent everything to your professors, but they have access to my Canvas page. If you can request them, they can download it for you and give you all. Okay? They have access to my Canvas page, my recordings, everything. Okay? All right, so this is just a slide for you to see how inflamed the airways are in asthmatic bronchiole. You know, when the spasm is hit here, the airways are much smaller. There is some mucus built up. So you want to relieve the patient by giving beta-2 relaxant or some steroids or whatever is needed to help these patients out. Okay. All right, next question. Any volunteer? Yes, Abraham, please go ahead.
Yes, ma'am. So when I read the question, I see we have a premature baby earlier than 25 weeks. I would say all of the above because we want to make sure that we give some type of phospholipids, so like glucocorticoids, which is pretty much a surfactant for the child. We do want to give oxygen therapy because you still need to have the child's smooth muscle start to work. So you need the oxygen therapy to carry and for her hemoglobin, and then the nasal continuous positive airway pressure, the cannula, you need it in their nostrils as well. So specifically for this 25-year-old child, I would give all three.
25 weeks, yeah. So
Sorry, 25 weeks.
And basically, the reason is that they haven't started making the surfactant yet, right? So if there is no surfactant, the surface tension inside is great, and the alveoli, they're just not opening up, they are contracted, right? So you want to open them up. The pneumocytes, which are making the surfactant, it would start from week 25 onwards, and then, goes on until I think 36 weeks or something, once they have full surfactant levels already present. So yes, for this kind of patient, yes, it's NRDS. Somebody answered in the chat. So you want to give them positive airway pressure to overcome the atelectasis, right? To open up the alveoli first. You want to give them oxygen to get, because they may have some ventilation perfusion defects already, which you want to overcome. And you also want to treat them with the phospholipid treatment, which is basically like a surfactant material that you want to supply so as to reduce the surface tension and open up the alveoli there. Very well answered, Abraham. Thank you. Yeah, you don't give them 100% oxygen, Danielle. I believe it's kept 30% somewhere there in order to get it going. You want to get the breathing going because while the baby is born, maybe there was some atelectasis which has impacted already ventilation perfusion issues, right? So you want to open up the alveoli and get everything aerated nicely. So, the exchange is going fine. I believe it's between 20 to 30%. You don't give them like full 100%. It's pretty dry, and it can impact the lungs. All right. Next question. Okay, if you are ready, just raise your hand. Yes, the older patients with VQ mismatch. You're right, Slamin. Okay, any volunteer for this? Yes, Aaron, please go ahead.
I was gonna say B because when you puncture the chest, you essentially lose your transpulmonary pressure. It becomes 0 when it's normally negative, I think -5. So what the transpulmonary pressure does is it keeps the lungs from collapsing and basically keeps the lungs from collapsing. So, and it pulls it back. But now the lungs are going to collapse because it's 0.
Very nice, very nice. Okay, someone has asked me a question. Thank you, Erin. Very well explained. Someone had asked me a question regarding the transmural pressure and intrapleural, I guess. So please make sure that you know the units. This is your intrapleural pressure, right? That you want to keep in mind. And the transmural pressure, can anyone tell me how would you calculate your transmural pressure? Alveolar minus intrapleural. Very nice. So someone who wants to understand, yes, Andrew, thank you so much. Centimeter of water are the units. Don't forget that ever. It's different than when we go for mercury pressure. This is water pressure that we measure here. So this intrapleural pressure is -5 centimeter of water right here. Okay. And this yellow arrow is going to give you your transmural pressure here. And how do you calculate it? 0 minus -5. So that's how you get this +5 number. Now, I just want to go back to explain the pneumothorax condition. So basically, the question had told you somebody had a stab wound, right, on the right anterior chest. There is lung injury. So if you look at this figure here, here are your alveoli, right? This is your intrapleural space, which has a pressure of -5. These are your alveoli, and outside atmospheric pressure is 0, right? So at rest, you will have same 0 atmospheric pressure inside the lungs, right? Now, what will happen if there is a stab wound? That means now this thing is open to outside, right? So what will happen if stab wound or puncture happened? Now this atmospheric air is going to go inside the intrapleural area, and it's making this pressure also equal to the atmospheric pressure, right? So this is all now at 0. So earlier, you can very well see this was our lung, right? Lung has the recoiling power and it tries to collapse. Whereas this is your chest wall, which tries to spring out. And this is held together by this -5, the intrapleural pressure that is sitting here, which is actually keeping the lungs from collapsing and this chest wall to spring out. So it prevents both, keeping it like a negative vacuum in there, holding two things in place. So if by a stab or trauma or something, this thing got punctured out, that means this is all now 0. The lung is going to collapse, right? Where the puncture had happened, now lung has collapsed, as you can see. So this is what we were trying to get at. Islamia, is it making sense for you guys? Both pressures go up. Okay, yeah, I'm gonna go to the breathing mechanism as I go to the next slide, and I will explain you more. But this is what basically is. So calculating transmural and everything will go to the next slide. But here, as you can very well see, this intrapleural pressure works like a vacuum in between the lung wall, the alveolar wall here, and basically the outside, the chest wall. So from this one tries to spring out and this one wants to collapse. So it's holding everything in place by holding this negative vacuum like pressure here, right? But if this was a stab wound or there is a puncture that has happened in the chest, basically you introduced air into the chest wall, right? Now that this is all at 0 at the same atmospheric pressure because air got in here. Now that broke that vacuum here. Now lung is gonna collapse in case of any puncture, any stab, any trauma, any bullet shot, or anything, right? So the lung will be collapsing. Is everyone clear about this? Are we good? Okay, now I can go to the breathing mechanisms. Actually, there is some chat. Okay, so here you can see how the breathing mechanisms are working. Let me go back to the slide. So here you can see, as I said, the atmospheric pressure outside is 0 and you have 0 in the lungs, right? And there is intrapleural pressure -5. This is all at the resting stage before you start the inspiration. Now, when the inspiration starts, which is basically your muscles, your diaphragm is contracting, right? It's making the chest cavity bigger. So if chest is expanding out, your lungs are inflating. As your lungs are inflating, the pressure here, which was 0, lung inflation is basically bringing this pressure down because the volume is increasing, right? So if you go by Boyle's law, which we're going to learn tomorrow, and I will explain this again tomorrow in class. So if your lungs are expanding, your pressure is going down there, which was 0 earlier. Now it's -1. Now this is also making a change into your intrapleural pressure, which is getting more negative because your lungs are expanding and your chest wall is also expanding, right? So now your transmural pressure, how do you calculate it? -5 minus 6.5, right? It is basically alveolar pressure minus intrapleural pressure. That's how you calculate. Just keep in mind, as long as your transmural pressure is plus or positive, lungs cannot collapse. But I'm going to give you some homework to do. So if you go back and read tonight, why in case of COPD, why there are airways obstruction happening when transmural pressure is getting to -5. So this is your homework for tonight, and we can discuss about it tomorrow. Let me know. If you didn't get it, I will explain it more. Okay? So Ahmed, what is your question? Amir? Amir, are you here?
Yes. Sorry, Dr. Kaur. I was trying to ask those
Can you say it loud, please? I can't hear you.
those positive values. Can you explain them, please? Just to clarify.
I'm not able to hear you. Can anyone else hear him and explain me what is he saying?
No, I cannot hear him, but I believe he's asking what those numbers are within the diagram. Like where did the negative 6.5 come from, as well as a -8 and so on. And
Yeah,
the left side of the diagram.
that's what I was explaining. Thank you, Vanessa. Thank you for answering. So, when you are doing the process of inspiration, right? Your muscles are working, right? So you have your diaphragm contracting, which is basically expanding your chest wall or chest cavity, right? If your chest cavity is expanding out, it's going to make this pressure more negative here. The intrapleural pressure, which was -5, is now going to change more negative because your lungs are trying to inflate as well, bringing more air in. Now, when they are expanding out, basically, this is Boyle's law. P1 V1 is equal to P2 V2. The moment your volume will be increasing, your pressure will go down. We will learn it tomorrow, as I'm saying earlier also. So if your pressure here, let me explain it further down. So now the process of inspiration is complete, right? It had expanded to enough, and the number has changed here to -8, even more negative, right? Now this lung is ready to recoil back, right? So now what is happening? As it starts to recoil, or the process of expiration starts to happen, recoiling back, atmospheric pressure was 0. It's changing to, so if your volume is decreasing, your pressure has to go up, right? So now what is happening? If your pressure is +1 here and outside is 0, air is just going to expire out from here. Does that make sense, Amir? And everybody else? If you apply Boyle's law, you're going to just, nicely go by it. P1 V1 is equal to P2 V2. That's how you remember your breathing mechanism. Yeah, the positive values, the yellow arrow is your transmural pressure. Yeah, that's your transmural pressure, which you calculate just by using your alveolar and your interpleural pressure. Yeah. Okay. All right. Next question. This should be easy and just testing your knowledge from previous. So patient is the coal miner complaining of dry cough for past 4 months. How do you think their spirometry results will look like? Any volunteer? All right. Michael is saying something. Very nice, Michael. This is B, right? As I explained you, it's a dry cough, right? Only 35-year-old. So for COPD to happen, you got to have certain things in the stem, right? You got to nicely read the stem. The cough is dry, right? So in COPD, you will see otherwise around, like there should be, phlegm or something that you are reading. It's cigarette smoking for some time or some other things. Patient should be, more age that you should be looking at least, 45 and above or something. It has to be going on for a certain time because it's a chronic obstructive pulmonary disease that we are going to talk about, not just for the past 4 months. And it's a coal miner, right? So silica, asbestos, all these things, these chemicals they set up the fibrosis in the lungs. So keep that in mind. And we already talked about the loops. So this loop will be representing what? C should be representing what? COPD, very nice, or emphysema, or it could be asthma as well, because they'll have hard time taking things out. But COPD, the numbers are very much lower than A. So as you can see and appreciate how lower it has gotten down, right? Okay, all right. I think we are doing pretty well. I'll leave probably rest of the questions for you guys to go over. The file is already posted, so I would say, just finish rest of the questions yourself and let me know if there is anything. Montana, Harlem, you can reach out to me. No worries. I will be doing at least one more review in between, and I'll give you the timings. I'll send you the timing. Yes, coal mining. Coal mining is not restrictive. It's the fibrosis is called restrictive disease.
Is that the same with asbestos as well? Because I couldn't hear.
Say it again.
Is that the same with asbestos?
Yeah, yes,
Okay.
yes.
Sorry about that.
Silica, coal, any particles or any residue that will stay and that can start the